Thank you very much for the opportunity to speak at this meeting, and it's a great opportunity to discuss further how we can work collaboratively between the UK and India. So Peter Drucker was a management guru, and he gave this phrase, "What gets measured gets managed." We want to manage AMR, so we need to work out how to measure it. Therefore, the question is, how do you make AMR measurable? And as we've already heard several times today, and we'll continue to hear over the course of 2 days, there are many issues around AMR. It's a global problem. It's dynamic. AMR is not a disease in itself. It's a component of drug-resistant infection, and it's complex, involving a large number of pathogens, drugs, and clinical syndromes. There have been a number of excellent estimates to date, including the O'Neill report from 2014, which have really helped to galvanise action, particularly people like Dame Sally Davis in the UK trying to drive things. It's great to hear about all the work going on in India as well. However, the estimates to date have been very much based on different methodologies and different studies, using different sources of data, focusing on different infections. And so you can't compare one study with another. It's not straightforward to put them all together. I want to talk today about a study that I'm involved in. This is called the GRAM study, Global Research on Antimicrobial Resistance. And this study is a partnership between the Institute of Health Metrics and Evaluation at the University of Washington, famous for the Global Burden of Disease Studies, and Oxford University. The study is funded by the UK Fleming Fund, by the Wellcome Trust and the Bill and Melinda Gates Foundation. And it has 3 main objectives. Firstly, to try to bring together all available data. Secondly, to produce maps of the AMR burden, which are as accurate as the data will allow at present. And finally, to incorporate mortality and morbidity estimates of AMR into the GBD study estimates. As everybody knows, this is a very ambitious thing to do, but we seek to provide an iterative framework moving forward. We have a large number of people working on this study. It's a study, as I said, between Oxford and Seattle. So in Oxford, at the Big Data Institute, it's led by Alan Lopez, who's a visiting professor, and a team of others, including Katrin Moore, who's here. So please come and speak to her and myself. Tropical medicine is myself, Christiane Dolsek, Nick Day, and others. And then over in Seattle, there's Chris Murray, Simon Hay, and a lot of other expertise there as well. We're initially focusing on 17 drug bug pairs around these bacteria, but we have a plan to extend into other bacteria where resistance is a big problem. We're beginning to get data in. We're working hard talking to collaborators in public health, in academia, in industry, in hospitals, with a variety of sources. So please come and talk to us if you're interested in working with us. There are a number of challenges, and I can't go through them all in 10 minutes. One challenge is the methodology, the choice of methodology. What outputs do we want when it comes to measuring AMR? What's important? Is it just mortality? Clearly, some lives lost, particularly in high-income settings, are very much at end of life. So it's important to think about DALY's years of life lost as well. What method do you use to calculate the burden? There's a number of options. Traditionally, the Global Burden of Disease study has used single underlying cause of death, but this doesn't capture the complexity of AMR, which is often a component with other diseases. For this study, we're going to be using a counterfactual approach to work out the attributable mortality. And when it comes to building the models, the assumptions within the models are important. The biggest challenge at the moment is getting the data, and we've already heard already from the previous speaker about some of the issues around data. What we need in order to estimate the mortality burden of AMR is line-level patient data. That's with the microbiology linked to clinical parameters, which include patient outcomes. And for this, we estimate we need ideally 48 parameters from a single site, which encompasses bacterial details, things about the laboratory, including quality control and the methodology, things about the healthcare facility, including the catchment size, the funding model, what type of facility is it, and then of course all the patient factors, including comorbidities and the outcome, and an estimate of whether this is community acquired or hospital acquired. There we go. So there's a number of challenges around the data, which have already been alluded to, and I'm sure we'll hear more about. First of all, the biggest problem is the lack of data for most of the world, particularly sub-Saharan Africa, but much of Asia, South America as well. Microbiology data simply doesn't exist. Clinicians are not taking samples, and there are no labs to analyse them. There is, as I would say, no culture to culture. There's no incentive for doctors to take a microbiology culture. The results come back 2-3 days later. It's not perceived to be useful. So you've got loads of healthcare workers who've gone through their careers without finding microbiology available or useful. Secondly, there's quality issues. We speak to a lot of people who have microbiology data, but in labs that are unsupported, that don't have a framework for using internal controls, standardized operating procedures, guidelines, external quality assurance or accreditation. So quality is an issue. And I think what we can do is try to raise the market, create the market for good quality data by having funders who want to hear about this data and people who want to work with it. I hope will create a drive to improve quality, and working with organisations such as we've heard from the previous speaker, national research councils and so on, to drive up quality in the lab and frameworks for quality control. The next issue we find is quite often there is good quality microbiology data available, but it's not linked to patient information. Often we're talking to microbiologists who operate as microbiologists, often without much contact with the clinicians. They get the samples, they analyse them, they send a report, the end. And there's no opportunity to link this to clinical outcomes. This data is still very, very useful for estimating the prevalence of AMR around the world. And we hope to be able to incorporate this data into our model, but above all, we need the data linked to outcomes. The fourth problem we find, and this is actually a very common one, we're speaking to lots of people who have a high quality microbiology data and they have patient databases as well, but the two are not linked. I expect a lot of you have come across this already. The two are not linked, and it takes drive and resources to get those two linked together. So we're trying to work with people in a variety of settings to get those data sets linked together. And again, we as a community can create a market for that kind of stuff being done prospectively moving forward. And finally, availability issues, where you get high quality microbiology data linked to clinical outcomes already. That hasn't just happened. People have put effort into that. Academics or other partners, public health bodies have worked very hard on that. They often can't just hand over data for analysis to other collaborators. First of all, there's concerns from the hospital the data came from. There's concerns about data misuse, patient confidentiality, even though it's de-anonymized. And then also there's academic concerns as well. People have their own research priorities as well. So we're talking with people about finding win-win models where we work together, where we have data for building the big model, and also working with people who are already doing the research on the ground, the people on the ground who really understand the local issues, are able to do the ground-up research to complement our bird's-eye view approach. There's a lot of other challenges I don't have time to go through, including the selection bias of the data that's available, the fact we don't know the denominators at all. The modelling that we're doing often starts off on North American data. Does it apply just to transport that to India or to Kenya? It's possible that AMR in the community is actually quite different and needs a different model to hospital-acquired AMR. And finally, the One Health paradigm. Our current project is not able to address this, but we hope to provide a framework for bringing in the One Health framework later on. I see an awful lot of opportunities for UK-India partnerships, collaboration to assemble this linked data. I would like everybody to join the dialogue around data harmonisation and the need for international standards so that it makes it easier for data, once it's in a database, to be in a format usable to other people. I don't think we're ready for the open source of this kind of data, but what we can do is make the pathways easier for the same data to be used again with the right permissions in place a second time. Lots of opportunities for innovation around how you do surveillance, around software tools, for example. Integrated genomics research, very, very exciting. Artificial intelligence strategies to interpret that. Novel drug and vaccine discovery, and of course the clinical trials of interventions such as point-of-care testing. So in summary, we need global surveillance systems that are built from grassroots up by the people in the labs, in the clinics, with an emphasis on patient-focused approach, which is a point that Sharon has made very well before, and I hope will cover in her talk. Our project, GRAM, seeks to produce an estimate that is as accurate as it can be at this stage and a framework for moving forward. The data and the modelling assumptions is the key. I think a key outcome of our project will be identifying the knowledge and skills gaps, defining what we don't know, and we seek to provide a framework for collaboration, driving the need for further research in this area. Thank you.